Well, welcome in everybody. Thanks for being here and spending time and all that good stuff. I've got a couple slides, but we'll keep it pretty informal today. Just enough to, I don't know, make sure you're paying attention and then we'll go back to the discussion. I'm assuming you can see my slide right now, but today we're going to be talking about healthcare shortages and real estate and how those two things intersect. And I'm going to just present the quick disclaimer. And by the way, this is being recorded. I'm guessing you saw the recording notification. This will be available on YouTube afterwards. If for any reason I don't think anybody will appear in the recording outside of our speakers, but just reach out to me if you've got any questions about that. All right. So first, what I want to do is just have all of our panelists. We have an amazing array of guests today go around and introduce themselves. So I'm going to actually stop my screen share for a minute before we get into the topics. Whatever order you want to go in, just talk about who you are, what's your specialty, area of focus, um, and what's your business and investing experience as well. So whoever wants to go first can go first, or we'll pick people.
We go by age.
Okay, perfect.
Amjad.
I'll go last. I'm the youngest. All right. My name is Amjad Hamad. I'm an ophthalmologist, vitreoretinal surgeon in upstate New York, in Saratoga Springs, New York. Uh, I manage Eyes New York, which is one of the largest ophthalmology groups in the capital region of New York. We have 5 locations, surgical center. I've been involved with the Jordanian American Physician Association, and we have several real estate investments across the country. I'm here to talk about my own personal and group's experience, as well as some investing experience, creating LLCs and groups invest in real estate opportunities.
Perfect.
Okay, I'll go second. So I'm Isam Abdel-Karim. I'm a hematologist and oncologist. I am in Northeast Arkansas. I'm in private practice. I'm currently the chief of staff of the healthcare system in the northeast of the state, and we're about 4,500 employees, 300 physicians. So we're always involved in looking for opportunities to buy in and join practices and expand. I'm like Amjad. We're involved with several real estate projects throughout the country with the Jordanian Physicians Network, and involved in real estate and some biochemical startup companies actually. So
Oh, great.
All right, I guess it's my turn. Baha Abu-Esheh, I'm a neurologist. I have my practice in Ardmore, Oklahoma. We have 2 locations, one in Ardmore, one in Oklahoma City, expanding to few more locations. Involved with the guys also through JAPA with some other real estate investments, and also founder with Al and Yousef InvestStream, multiple different projects in different areas of real estate. We have different investments in car dealerships and restaurants and different other minor things.
Perfect.
Obviously, I'm the youngest in here. My name is Yousef Abu-Esheh. Um, I'm a former pharmacist, retired, if I would say, retired pharmacist, managing partner for neurology care. I'm doing different businesses. Me and Baha share a lot of investments together, and Al also in InvestStream. We started in early ages with restaurant business, different industries, car dealership. And our last investment or big investment was starting that InvestStream real estate company. And we invest in multiple things. I was thrown into the medical field from a pharmacist to managing and growing the neurology care with 2 locations. We are a total of 2 neurologists and 9 mid-levels, total of almost 50 employees in 2 locations. And we're growing day by day with multiple locations.
Great. Thanks, everybody. Those were wonderful intros. Okay, so now you have a feel for why we've invited everybody to be here and talk about this. And what we wanted to do is start by talking about healthcare worker shortages. And there's a couple of statistics that I pulled, but I think it's always best to hear from personal experience. So I'm going to share some of these, and then we're going to have a discussion about some of the things that you've seen personally in your practices and, practices near you, all that good stuff. So there are deficits in a lot of different areas for healthcare workers. These are just a few. One is that there are an estimated 73,000 nursing assistant. There should be a deficit of 73,000 nursing assistants by 2028 and a physician shortage of about 122,000 by 2032. Um, Now, we do a lot in Texas and Oklahoma. We've got folks here from Texas and Oklahoma. I didn't pull every state, but I was looking at adequacy levels, which is really, is there sufficient physician coverage in the state to match the population? And so 100% would be, it's adequate. Under that would be not. And I didn't go into specialties specifically for this, but just kind of statewide. So Texas has 109% adequacy. And just for comparison, Oklahoma is at 80%. Every state's a little bit different. And some of the lowest levels of supply adequacy include vascular surgery, thoracic surgery, ophthalmology, family medicine, and plastic surgery. So those were some of the statistics I was able to pull. But what I wanted to hear from all of you are things that you've seen in your geographies and your specialties in terms of these shortages. And again, whoever wants to go first can share some of the things that they've seen.
I can get started again.
Perfect.
Being the youngest here. So I think we all realize that in healthcare, the demographics are very positive. If you're in the healthcare field, the demand is increasing rapidly. We have the baby boomer generation, which is getting older and asking and requiring more services, time. In ophthalmology, in my field, we are projected over the next 5 to 8 years to need to sustain about double the amount of ophthalmologists that we currently have. And I can tell you there's no way, shape, or form that the training programs in ophthalmology in this country will be able to provide that in the next few years. A lot of the physicians are also, if you look at our physicians there, they mirror their population. So a lot of the physicians are baby boomers and they're about to retire in the next 5 to 10 years, a lot of them. So we have retiring physicians, we have increased demand in healthcare, and we're all scrambling to meet that need. So as far as you can think of that as positive or negative, but as far as an investment opportunity, and especially as in healthcare, any way you invest in healthcare is going to be good for the investor, and there's a lot of potential. And it is, by definition, it's a necessity. So it's recession-proof. So the normal cycles of the economy don't really impact healthcare and healthcare demand.
I guess I can go in a second. Can you just keep the same sequence or mix it down the road?
Perfect.
So, oncology has a specific good problem, which is people have been living longer and longer with treatment. Gone are the days that most patients with stage 4 cancers will die within a year or two. We have many patients who live years and years. So, instead of seeing, 15 patients in the clinic in training, now we have to see, let's say, 20 or 25 or 30 patients because they're just alive. They are on treatment, so they have to be seen. So it's a great problem to have, obviously. We're extending survival, but there are limited training spots. The training spots are limited by funding from the government. It's very expensive to train new physicians. I'm not aware of, many fellowship programs that opened in the last 10 years, maybe 2 or 3 in oncology. My program in San Antonio, they used to take 4 fellows 30 years ago, and they still take 4 fellows every year. They haven't increased it by 1 fellow. So they have 12 fellows in the program. That's it for a city like the size of San Antonio. And they're the only training program in the city. The other problem with oncology specifically, and I'll touch on another specialty, is that, oncologists, some of them practice late in their life, but they have a burnout. Many at like in their 60s, or like baby boomers, or like even earlier, they're like, you know what, that's tiresome. It's draining, it's emotionally draining, taking care of patients sometimes, especially in oncology. So they either go part-time or they just stop and they retire. Some of them retire indefinitely, and some retire and start having, locum jobs. So they go back to the market, but they're very limited in what they want to do. They want to work 2 or 3 months a year. We've had in our area, oncology is decently covered, I would say. But like in Arkansas, I can tell you in Northeast Arkansas, it has been extremely hard to recruit gastroenterology, GI has been extremely hard. It's actually a bit easier to recruit neurosurgeons and cardiovascular surgeons than GI. Somehow it's just been hard. We've been trying to add, but it's specific to our market. And they have the same problem. Many physicians are retiring early. They're not adding new training slots, and patients are needing more testing done. So,
All right, I guess my turn. So I think there are some universal things among all specialties, the aging population and increasing demand of care. Of course, there is some variability and geographical factors where rural areas versus urban areas. In neurology specifically, there has been a taboo about neurology that, there isn't really a good outcome. People have stroke and you can't do anything. But over the last maybe 20, 25 years, there has been a major shift improving the outcome for neurological patients, plus increasing survival rate for those neurological conditions. So you see the demand is increasing with that. Now, as of 2012, the shortage in neurologists in the US was 11%. As of this year, it's 16%. And it's also expected to rise because we really have aging population, especially with the dementia population. We tend to live longer and we're going to need a lot of more neurologists. Now, on average, they're expecting like 1 to 10,000 population need one neurologist. Now it's probably getting like 1 to 16,000 or 16,500. Some rural areas like 1 to 100,000. In Oklahoma, the average is like 1 to 19,000. Now, in our area in southern Oklahoma, it's almost we have the population of 121,000 as of 2022. And I'm the only neurologist now with the addition of the other neurologists in a few months that we're going to be serving all this area.
I think me and Baha will share a lot of statistics together. We are in the same industry or the same field of neurology. I remember last market research we've done, for example, in Oklahoma City market. Oklahoma City has, they're fulfilling 1/3 of the need for neurologists. I believe there only was 12 neurologists for I don't know the population, the last number it was huge and the need is huge. And for your point, Sammy, I think the number is 139,000 shortage by this year. And most of the doctors, 45% of them over the age of 55. So they're closer to retiring. And for some reason, a lot of people start being shy to go to med school and graduate and be with higher specialty like neurology or ophthalmology or oncology. So there is a huge need and there is a shortage, and waiting time for those patients is insane, with 6 to 10 months wait to see a specialist in some areas.
Beautiful. I'll jump in. And thanks for all of our panelists for joining us today. They're literally my friends, cousins, and brothers. So I appreciate you being here with us tonight. I'll follow up with the question of, given these challenges, how are you managing? Is there any new strategies, maybe lower level providers, consolidation? Like what's some methodology that you're using to respond to these shortages, and how does it impact growth as well?
Oh, again, for our field, I think like as in most other medical fields, the name of the game is efficiency, to get as efficient as possible. And with the MD or the healthcare provider, time being so precious, we're really trying to give them as much support as possible so that they can have be able to do the things that only that healthcare provider can do, what their license allows them to do. So we have to provide the doctor or healthcare provider with enough support, enough staff to be able to bring patients in efficiently, process them and have them be ready for the doctor to come in, or the nurse practitioner or the healthcare provider to come in, talk to them, and be able to provide the point of service care, and then move on to the next patient. But the same way as we are being efficient and we have the throughput we're talking about, there should be no compromise at all of the quality of care. So that's a tough formula. It's kind of a balancing act to be able to make that happen. And technology is a big enabler. So there's a lot of technology, and you will hear about telemedicine and virtual visits and all that stuff. But in the essence, in a nutshell, the core of medicine is the relationship between the doctor, the healthcare provider, and the patient. And technology can only go so far. We're all in this Zoom meeting here, and it's nice for us to be able to. It's very convenient. But again, the connection, the human contact is necessary, particularly in healthcare, where we're talking about, caring and providing care and the human touch and the human contact. So there has to be a means of the patient being able to go to a physical location and actually be with the healthcare provider. And I think that's what we're talking about tonight with the real estate, is that even though we are trying to utilize and leverage all the potential of technology, we have to provide more points of care that are accessible, available, and easily utilized by the patient where they need them, which is very close to their home, very close to their point of work, it's a constantly moving target, but we're trying to do as best as we can with the resources that we have.
So to build on that, specifically again to my specialty, we've added several mid-levels, so if we can't recruit physicians, sometimes we just have to make them more efficient, like Dr. Hamad said, plus add other providers. We've been lucky finding mid-level providers because we have a college here in town that they have a school for mid-APRN. And there is a physician assistant school in Memphis, which is an hour away from us. So we've been very lucky adding those. Now, in oncology, they need to be trained, and they're very helpful. But sometimes it takes months to train them. So there's a slow time there, because it makes me a bit slower because now I'm training, but it definitely pays back. And the other thing, low turnover. We pride ourselves in the practice here about low turnover. My nurse has been doing oncology for 20 years. Many of our employees have been with us. I call them the front lines, the nurses and the mid-levels. The average is, I think, 10 or 15 years now. I mean, I have been with the practice for 7 years, and most of them have been longer with the practice, with my senior partners. So that helps, because that makes you efficient, that gives loyalty. It's actually less expensive because now you have less downtime. And then the other thing is we add sites. So we have an outreach site that we go to. It's about 25 minutes. We capture another part of the state plus Missouri, which is next to us. A specific problem and our healthcare system has many clinics within probably an hour. We have a specific problem. It's hard for us to have an infusion or chemotherapy suite everywhere, because these patients have to be monitored while they're getting their treatment. You have to have a physician or a nurse practitioner all the time during that time. So it becomes a bit harder. So we have to see a lot of patients in the main cancer center. A bit about telemedicine. I like what Amjad mentioned about the personal touch. So during COVID, we came to this question. Many of the departments within the system moved to telemedicine. We just sort of refused, actually, me and my partners. We said, if they're coming to get their treatment, we will see them. If they can't make it, then they're not going to get chemo or immunotherapy or something. Then we could call them or something. We felt that telemedicine lacks that personal touch. I have nothing against it, but specifically in oncology, we just needed to see the patient. We just needed to, listen to them, put maybe a hand on their back and encourage them and see how strong or weak they are before they get treatment. So just a word about telemedicine. I mean, I haven't done telemedicine, so I'm the least experienced probably because we just didn't do it during COVID.
All right. So I don't need to repeat really what Amjad and Sam said. Of course, efficiency and technology and eventually AI, it's still in an infancy. We're learning more and more about using AI and technology for improving patient care and increasing access. I'll tell you my personal approach. What I did a few years ago, I dropped the inpatient service and I focused on my outpatient. And because of the availability of telemedicine that they can cover inpatient or acute cases, and probably the preference for outpatient, so I can focus on that and grow. The other thing is mid levels. I know some people might feel skeptical about that issue, but as Isam said, if you train them right and you're there all the time, I think they're going to be great assets. So that's one of the tools that I used, which really improved the access for our patients. But I'm always available for my mid levels, always for questions, not necessarily just they've been with me 2 3 years that they're on their own. No, I have to be available for them, especially with all us as subspecialists. You need to be there all the time. Now, the other thing is you're trying to help patients not to travel to get a lot of these testing done, and make sure you have diagnostic tools available for them where you practice, especially in small towns. The other thing, as Sam said, of the recruitment. So recruitment and retention. I think this is an art. A lot of people might not pay attention to it. The retention of employees, retention of mid-levels, you have to do it right. It pays back on the long run. Now, there are some more few points. We're trying to get involved more. We're being part with the Independent Physician Association in Oklahoma City, which one thing we might not pay attention to is getting engaged with legislation. So we're trying to get some people who are really into the government or with the state that we can, sometimes they write some bills. So we're trying to build really good rapport and connections with them. Now, probably most of us here, we're going to just try to push, say, in private practice versus being employed, because the issue, the bigger the system, the more red tape you have, the more struggle. Definitely you have issue with access for patients to see specialists. I can tell you a personal experience, my wife to see a primary care, because it's part of the big Mercy system, there isn't really an easy access to get hold of the doctor, to get hold of the mid-level, getting probably to be seen in a couple of weeks if needed. So that's what I've seen, and a lot of people would probably agree with me. When you have big system, it's not really a good access, while private practice might provide that. So you have the flexibility, you don't have the bureaucracy and all these things. Now, in terms of the other approach in the business, we talked about, should you have more small clinics, more satellite clinics? So that's the approach we did. We're trying to build or cover certain geographical areas. You want to try to help patient with access in rural areas. And trying to consolidate and be in one area, I think it makes it harder for patients. So having satellite clinics, maybe with centralized location for scheduling of the back of the office work, that's our approach have been and has been really successful. So you have to balance how big you want to get the size of a clinic and the geographical coverage versus having, as I said, a large clinic and just you have those patients travel. And a lot of our patients like Medicare, Medicaid, aging population, they really have struggled with this. So I think the approach has to be balanced with this when thinking about centers or consolidate clinics versus small clinics.
I don't think I'm going to add to what the three doctors mentioned in terms of efficiency, but there is also an art of being efficient, but you still give that feeling to the patient that you're giving them enough time and taking care of them. And that's a very fine line that's hard to achieve. you're like most doctors can make decisions and come up with a treatment in less than a couple minutes. But if you spend just a couple minutes with the patients, they're not going to be happy. I mean, all doctors know that. So efficiency is an art to improve access. One of the things I was going to mention from an operation standpoint, you try to eliminate everything that the doctor or anybody else other than the doctor can do that does not require a licensed practitioner to deal with paperwork or prior authorization. Some doctors in private practice, they used to assign 1 day just for admin work. That's, of course, slow down the access for patients. If you have somebody with you who can manage those things, that increase the number of days for doctors to see more patients. But at the same time, they will be burnt out. So it's just a fine line you need to keep balancing between here or there.
And we have in Investream the ability to do major projects with many partners, but with a very small team, because we leverage technology, we leverage state-of-the-art tools, collaboration tools, research, analysis. So kind of going backwards, so you can start, Yousef.
Yeah.
Use of technology, use of wearables, AI, home care, anything that you deploy that even make the process faster and the treatment more accessible.
Sure.
Yeah, anything specific anyone uses for any of those
Uh,
tools? We had a couple of questions in the chat about it.
Oh, so that's what they asked. I mean, technology usually incorporating AI for dictation, for example, for physicians will help them with their notes. That will help a lot. One of the new technologies, we did not start using it yet, where the doctor goes in the room with their phone and just record the conversation, and AI will build you the whole chart. That will improve efficiency for those physicians where they can see more patients. It's just the art of operation and technology where you can use it without affecting patient care, without giving that feeling to the patient that you're just a number. I'm here to take care of you with the minimum amount of time.
Anything
I,
anyone wants to add? I know
I
you.
can add a little bit more about the wearable devices. Of course, in the sleep medicine world, this is an evolving thing all the time. Just even, I think today probably or yesterday, me and Yusuf were talking about it. So Apple Watch, they're gonna come up with the new Apple, I think, Watch 10 that can
Hmm.
detect possible sleep apnea. So it's a very evolving, which actually can get you patients diagnosed faster and treated faster. So that's one thing in the world of sleep medicine. In EEG, also remote monitoring, that's another thing has been better the last 10, 15 years in terms of diagnosis. Instead of having patients be admitted to an epilepsy monitoring unit and which cost is extensive. So maybe 10 times more what an ambulatory video EEG would cost. And probably it's comparable result, almost 90% you can get if you do an ambulatory compared to an epilepsy monitoring unit. Beside the wait time for epilepsy monitoring unit is amazing. It takes probably a year or two to get to one of those.
And having the tools and technicians to even do the setup inside the patient house. So it will minimize the travel for those patients. A technician will go and do the setup in their houses and take care of the patients over there. And the doctor will read it remotely and monitor remotely. So technology helps a lot with those things.
And yeah, in the field of ophthalmology, there's not a whole lot of wearables in that regard that I can talk about, but remote monitoring and remote testing is definitely in everybody's mind, and we're looking at better and better technology with that. I know there's a lot of remote clinics where patients cannot travel to an eye doctor office, where they will take pictures, cameras for primary care doctors, take pictures of the back of the eye, the retina, and AI will look them and screen them and check for diabetic retinopathy, damage from diabetes. And it will flag the suspicious patients for an eye doctor to look at or be referred to a specialist to treat. There's also a friend of mine in Florida is working in a company that is creating booths, eye exam booths, And the idea is to put it into airports and to put into pharmacies. And you can access those any time of the day, even at night. You can just walk in, sit down on a chair, and basically it has it has like a virtual reality device, I guess, where you can check your vision, check your visual field. It'll take pictures of your front of your eye, the back of your eye, there'll be an AI algorithm that will figure out if there's any pathology, any abnormality, and it may do a refraction and give you a prescription for eyeglasses. And you can order the eyeglasses online. So how about that?
Interesting.
That's insane. Isam, the AI in your world.
In AI, so, there is in oncology, we have, chemo pumps and it has their own AI and stuff. There's actually in the dictation systems, we do a bit of AI to understand things. But what's very interesting in oncology that's happening now in clinical practice, there is a lot of interest in is screening for cancer. So, CT scans. So people get scans all the time for all kinds of reasons. Somebody goes with an abdominal pain to the ER, they get a CAT scan for their chest, and there is let's say, a 1 centimeter lung mass. Well, the abdomen is fine, but somebody has to follow up, and this 1 centimeter lung mass could be the beginning of lung cancer, which you don't want to miss. So the system is fed, thousands of scans, even in our system only, thousands of scans every day, and there are not enough radiologists to look at that all day. So there is an there are AI systems. There is a couple on the market, I think, and actually I'm involved with a company that's developing one as well, to just scan, look at those scans, identify them. Does that look suspicious? If it does look suspicious, then it generates actually a message to the radiologist to look at it, and then they contact the patient to come for a repeat scan or for a biopsy. And if it doesn't look suspicious, it could be monitored. Then there is a generation for like communicating with the patient, come back in, like, let's say 3 months or 6 months. So that's been very interesting. There is not to nix any radiologists, but they've done a big study when they actually looked at the AI versus radiology, and the AI was more accurate in detecting lung cancer than board certified radiologists when looking at scans.
The opinion, the
Take
panel.
it with a grain of salt, that study.
We don't support any statements.
Yeah, like,
Yeah, exactly. But yeah, we mentioned that, and we tease them, and it's like, come on, Isam. So it's like,
One of the things in one of the conferences I attended, they were talking about AI in radiology. They use AI to look at the data before it comes to radiologists and put it in order according to how severe the case is, so that the radiologist can look at it faster or before other normal results.
Yes.
Yeah, we have in my days in oil and gas, we used to have a scoring mechanism that we asked the practitioner, subject matter expert, to continue to score. Let's say the AI said this, and the radiologist said this, or the drilling engineer in our case, or the production engineer, and they would say yes, no, yes, no, it did, and then all of that fed back into the AI as a feedback mechanism. So they were part of the process as opposed to being a competition. So.
Which is Baha, the scoring for sleep studies, it's done by AI nowadays, right?
That's
remember,
true.
sorry, AI read ECG, AKGs like 20 years ago when I was in residency. There is a read. I mean, that's sort of an AI module too, and they keep getting better as well in reading things. So
We're every time we say this is amazing, this is incredible, what else will they come up with? Next generation, next iteration is even more. It knocks your socks off even more. So I think we're the tip of the iceberg here with the AI revolution. We all know that it's gonna completely change our lives for everybody. Healthcare is not insulated. It's just like any other field. I was talking about the oil drilling and the engineers and so on. Every field is going to be affected with AI. In healthcare, it's wonderful because we just, as we touched on in the beginning of this meeting, about the shortages and efficiency and how we can bolster that and add capability and add capacity. I don't think it really is, as everybody said, and Isam has said so also, and everybody has. It's not a competition. It's not basically physician against AI. AI is a wonderful tool, and therefore, how can we utilize it the best? And I think the best results are when we get that human being with the tool the right person with the right tool at the right time. It's always been that way and always will be that way.
Yeah, if you watch Terminator, don't let Terminator pull the trigger. Just let him know. Because there is a question from Hani, great questions. He's an AI practitioner himself
Yes.
about like, do you think that doctors are going to be sued because of using AI? I always see AI as an assistance, and
Yeah.
the final call is for the
It
doctor.
always will be. It always will be and always should be where there's a human being finally at the end of that stuff. How many layers and how good it is, that's for the courts and ethic boards to decide in the future as technology advances, whose responsibility is what. And so I'm there right now, at the stage we are in right now, it is always the doctor's responsibility to use those tools appropriately.
Very good.
But
Let's
here's a
take.
question before that, Al. One
Yes,
one
yes.
minute.
Tell.
Do you think for doctors, do you think AI will eliminate some of the specialties?
Well,
Ah.
there are some specialties that they're expecting, like radiology and pathology. Those are the top two that they might not completely disappear, but severely affected by AI.
And I think that's just right. I mean, I don't see anything, as I said, there'll always be the need for the human being or the alt specialist or the ultra specialist to double check. You know, you want to have a human being eventually behind all those machines. But I think as far as need for, we may need less radiologists, we may need less dermatologists, we may need less pathologists because there's so many tools and so much efficiency in the system. But I doubt whether we're going to see anything that's going to completely disappear.
Here's one for you, Yousef.
Go for it.
Pharmacist and accountant.
I mean, I, I made that decision like long time ago. I know it's coming, so I retired.
Lawyers too, paralegal. I mean, that's AI
Oh, we use AI all the
directly.
time to draw our own contracts. We can have
Yeah.
a whole session about AI in real estate. I think everybody's going to geek out on that.
Yeah. But I
So
think to add to this, especially what Amjad said, is like look at AI for autonomous driving. You're never gonna have. I don't think you'll have cars driving themselves. Widespread. You have to be behind the steering. I mean, my wife has a car. I have a car that has some kind of autonomous driving, and it makes mistakes constantly, and it stops when it shouldn't stop, and it goes when it should not go. So I mean, not to mention the brands, but they are advanced cars. So you always have to have a human supervising all these activities.
Look at airlines, look at
Yeah,
airplanes.
exactly.
I mean, airplanes are being flown right now 95% of the time by a computer, right?
Mhm.
Autopilot. But when it comes to the tricky part, when it's landing or taking off, there's a human being. And
Correct.
I will never want to get an airplane where they tell me, you know what, the computer is flying this, and don't worry, and we don't have a pilot on the plane.
Yeah,
So
exactly.
I don't think any patient in the next 20, 30, 40 years is going to be happy to go to a medical office and say the computer has made the diagnosis, take this medicine, or this surgery will be done by your robot surgeon without actually thinking about there's going to be a human being somewhere in that loop, right?
I'm glad you mentioned that because we still need real estate. So
Yes.
let's
Yeah, this is like the perfect transition, really,
Yes.
yeah. So
for
let's
this
move on from the virtual to
to
the brick
the
and mortar again.
personal. Yeah.
And every business has its own. It's never absolute, and it's there's the opportunities and the threats and how we handle that. So go ahead, Sam.
Yeah, no, this was great. I mean, a lot of you have covered some of the points that I was going to bring up. I think it all ties together so well, but talking about creating efficiencies and doing things in a way that can be closer to patients and all of that, all of the ways that you can address a workforce gap. Um, I'm looking at it, surprise, surprise, from a real estate perspective. But a couple of you touched on this, having smaller clinics within 10 minutes of patients, having a more localized footprint, and having specialty care facilities located within 15 to 20 minutes of patients. And, it's not necessarily looking at a health system, instead having these, smaller facilities. And I think one of you mentioned like remote technologies, things like that, remote. Yousef, I think you talked about remote EEG.
Mhm.
Yeah, that kind of thing, having technologies that are able to be facilitated in these outpatient, clinics that weren't a thing, not too long ago.
Mhm.
We also pulled a couple statistics on the growth in medical outpatient buildings. So here you can see different facility types. You see that medical outpatient building far outpacing, hospitals and home and residential care in recent years. Um, and also these projects coming up that are not hospital adjacent. So 81% of projects averaging around 26,000 square feet are not hospital adjacent. And then we also see commercial real estate investment sentiment improving. So of course we're talking about our angle a little bit, but really what I want to do, talking about some of these statistics, is any real estate shifts that you've seen. So some of you have talked about this already, kind of those smaller clinics being closer to patients and all of that. But anything else that you've seen in part in response to these shortages or patient demands?
Yeah, if you want to open a new clinic, what's your criteria? Size, location, style, etc.
I I can get the ball started if you guys on. We've been in expansion mode because in our group, and we've been looking at adding more clinics and more centers. I think the hub and spoke model, which we've been discussed many times already, Isam and Yousef and Baha has been talking about it. It seems to be the way that most practices or the most healthcare systems are going. There are very expensive items, expensive diagnostic equipment, MRIs, CAT scans. For us, it's fluorescein angiography machines and expensive cameras that we can't afford to put in every single location. So there has to be a little hub where you have all the expensive items and where you have the sub specialized doctors, the different specialties, which is really hard to recruit, and you don't have maybe one or two for the whole town. You put them in a central location, right? So patients can access them easily. And then what you do is you create the spokes, the little satellites that are out and integrated in the population. They can take care of most of the problems, can take care of the triage, take care of the follow-up, the screening, and then refer the ones that need the services of the hub back into the main office. Our sweet spot for a main office is about 3 to 4 physicians. Anything more than that, and the capacity gets a little extreme. Because you need a lot of support, a lot of people, a lot of staff, and so on. When you get more than that, our hub is around anywhere between 6,000 to around 10,000 square feet. That's the main office. And as far as satellites, we have 2 to 3 doctor suites, and that usually anywhere between 2,500 to 4,000 square feet.
And do you like to be standalone within a shopping center, office building? Any preference?
Absolutely standalone. I mean, I think the days of doctors conglomerating together and occupying a professional building right across the street from the hospital are no longer. That whole paradigm has shifted now, and especially in my field, I'm talking primarily about my specialty in ophthalmology. I mean, you can walk into any mall and you'll see lens crafters and you'll see Vision Works and so on. So this is part of the competition, the industry that we're dealing with. Eye care is a continuum. Obviously, and you've got all kind of different levels of care and locations. We like to be where the patients are, and we really look for easily accessible locations, close to highways, and we will look at retail centers. In our town, Saratoga Springs, the hospital actually took over a big chunk of the local mall. The mall was dying, anchor stores were going away, and the hospital moved in and grabbed a chunk of a big, I think it was a Sears, and converted a big,
Wow.
massive footprint of Sears into a hospital outpatient clinics. And I thought that was amazing. I mean, it was such a win-win solution because that mall was going to go out of business, and now they got a big client, and patients loved it. Right, it's in the mall, right? You go, there's big, nice parking, easily accessible, and you go in and you see your doctors there. I thought that was great.
Very good, Asam.
Sure. So, our approach as a system depends on the specialty. So, like I mentioned, and I'm just alluded to, is like we cannot have a cancer center, in like 10 towns around us. So we're a bit unique in the sense so Jonesboro is a college town. It's about 80, sometimes the people say it's 100,000 with the students. So we serve 23 counties, about 750,000 population actually. So we're sort of like the city in Northeast Arkansas. We're the biggest, place that people come for healthcare. So back in the day, the hospital has been around for 125 years. So they started in downtown. They're celebrating 125 years this year. and then they started adding. So the space is a challenge, but the main hospital has been, around for a long time. They've added in brand new towers and ICUs just before COVID in downtown. But then every time there is a building that comes on sale, the system, they will buy it and then they will make it into physicians, offices. So there is a building for cardiology, the cancer center next to the hospital. There's a building for OB, pediatrics down the street, imaging centers down, hospice house. So it's over several blocks. If you know, like, Cleveland Clinic model, or, my clinic model, same thing. I mean, obviously at a smaller scale. So this has been good in the sense we're spread over several blocks. I mean, the challenge in space actually was a good problem to have, because they're expanding horizontally. They're not spending much vertically. We don't keep adding floors. Now, there is another healthcare system in town, which is based out of Memphis. So we're about 500 beds. They're about 200 beds. What they did is that they took a big chunk of land a bit north of town, and they just built a new hospital with clinics, with everything in that same place. So that's their model. I mean, I'm not critical of it, but it creates congestion in that area because everybody is there. Now, what the two systems did, you just can't bring all these people from, like, here. So they will go in, and let's say there are the towns within an hour from us, actually, just about an hour from us. They will open primary care and some specialty clinics. Like oncology, we cannot go to these towns because we cannot just have a chemo suite there. But cardiology would go. They will take an EKG machine and echo machine. Neurology can go. We have shortage of neurologists. But like GI will go. They'll have an endoscopy suite for them. A bunch of primary care, pediatrics. And then what they did is they put CT scans and X-ray machines in almost many of these locations, and then the radiologists will read them, remotely, because, it used technology, like we said, to expedite things. So the patient will get a CAT scan, and then it will be read the same day by the radiologist who's sitting somewhere else within the system. Depends what they're covering. So we cover a big area, and I think it's efficient. There is a lot of driving involved by many physicians. They have to drive sometimes an hour, but they share call. And then, if you go to an outreach clinic, it's probably 2-3 times a month when you have to drive an hour. And they try to make it as efficient as possible. So you see a lot of patients, you take a big staff with you. And I think it works. You bring care to these communities. Many times, though, they have to come to the main city to get, specialty care, cancer care, big surgeries, stuff like this. So it's a combination of several things, and it's solution to problems we've had, and I think it worked out well.
And those satellite offices where you have family care and some specialties, are they standalone?
They're all standalone. Like I'm just saying, everything is standalone. I don't think we share space with anyone else.
And what
It's all
about
standalone,
size?
and many of them have been built new, or they were taken over and completely renovated.
Nice.
Well, on my perspective, I alluded to this earlier about the approach and have a central hub and satellite clinics. But in terms of how we approach this and the real estate, I want to defer to Yousef because he has been studying the market and just any location we're thinking about. We've done feasibility study and he's been driving and looking at this market. So I'll defer to more details to Yousef.
Criteria is very simple. We look for, in our specialty in neurology, shortage where there is a need for neurologists and neurology services in that area. But at the same time, we need to find an area where we can find providers and mid-levels, not just have a shortage, but you cannot recruit providers. I like to be in a medical area like the one we opened in Oklahoma City, surrounded by a lot of specialties from urologists to women health to dentists to primary care. So I like to be in an area where the patient will drive to a medical community, if I want to call it. In terms of an office on how many rooms, I like to plan 5 to 10 years usually. I go with number of rooms, 12 to 15 exam rooms where you can accommodate 3 to 4 providers. I like standalone, very specific, but if I'm in a medical or a shopping center or a medical building, I like to have the services that will help our specialty. Again, I'll go to the example of Oklahoma City. We have lab in the same building. We have a pharmacy in the same building. We have infusion center in the same building. All those three helps neurologists if you want to order infusion or send a prescription or order labs. Same area has like imaging also, radiology for MRIs and CT scan. Specific criteria is usually we look for when we expand.
Very good. I think this concludes our line of questioning. It'd be good to open the line for anyone on the call who would like to have any question. And if there's any question we didn't cover so far that was shared on the chat.
Yeah, I think we've addressed everything in the chat. If anyone wants to ask additional questions, you can put them in the chat. You can unmute, feel free.
I have a question for you guys. Thank y'all so much, first of all, for your time tonight and for providing some insights to your experience. One of the things that's happening here in Houston, specifically with Houston Methodist, is the constant expansion out from the central location, which is forget what we call it now, but it's the medical hub in Houston. They're in Third Ward. They're continuously to spread out into the suburbs to have these satellite campuses. For you yourselves, how does that competition affect your ability to retain clients as well as to continue to have vibrant businesses? Or is that something that happens and that y'all face in your areas?
I mean, there's always this talk about, big systems swallowing smaller systems. I'm not against competition. I think sometimes it's good. Sometimes it's taken too much. Houston is a very tough market. I trained in San Antonio. I have a lot of friends who are practicing in Houston. Cleveland, Ohio is a tough market too because the University Hospital and Cleveland Clinic basically divided the town. So you have these systems which drives out smaller ones. But, I mean, I remember we used to whine about it a lot. I think, past whining, you just have to adapt and provide a better service and, please these patients. And, I tell people in also, out of training, we have a residence and, some of the fellows is like, not everyone has to live in a Houston or Cleveland or New York City itself. There is plenty of good life and medicine in smaller cities that have less competition, definitely. And if you are dead set on not being part of a big system, maybe then, smaller cities will suit you better and you'll have more you'll have more time, you'll have more things to do, and there is definitely less competition. But the US is market is very interesting market. So
Definitely, it's very variable. And as I said earlier, sometimes there are some patients might not really be enthusiastic about going to a big system. They know the access, they know maybe, I don't want to say the quality of care. There is a taboo about that. So they like to go to independent physicians. Some people like to go, okay, I'm going to go to a university hospital. I get the best care, best people trained there. But what we've seen, at least with our experience the last 18 years here, there is really some shift away from bigger systems going into smaller independent physicians. And I'm sure a lot of the other doctors might share the same point with us.
I agree 100%. You hit the nail on the head. There's enough patients for everybody. It's not like we are lacking for patients. As we said, healthcare demand is booming. I think the service offering in a big healthcare system is often quite different from what you get from a private practice, a smaller private practice, and there's more emphasis on more personal touches, possibly. And again, I'm not trying to generalize. I mean, there's wonderful healthcare systems, wonderful healthcare physicians that provide fantastic care. But I think the patients will gravitate towards what they want and they need. And obviously, everybody's doing well. So I doubt the doctors in Houston. I mean, even they may talk about the spread and being in direct competition with each other, healthcare systems and so on. But at the end of the day, we're all doing the same thing. We're all trying to take care of our patients, and I think it all works out.
I mean,
I'll
competition makes you better all the time. I mean, competition makes you better all the time. But as we discussed at the beginning, there's a huge shortage. So it's a necessity. Healthcare is a necessity. So you're gonna be busy. You're gonna be overwhelmed with patients, even with big systems or small clinics. You're gonna have more or enough patients more than what you need.
I want to add a little bit to what Amjad said. When you have a bigger system, the loss of personal touch. So a lot of people in a bigger system, they have to go by the book. Meaning, so let's say you missed an appointment. There is rule, okay, you're gonna go with the next appointment available. It's gonna be like a month or 2 months, and nobody can override that. They're just going by the book. But in a small independent practice, there is some personal touch where, okay, well, we can get you back in a few days. So I've seen that happening a lot with our patients.
I'll give you a quick example to add to the point. One time I took I'll name the system actually. It's Labanar system, which is a great children's hospital in Memphis. I was taking my daughter to just a regular visit. And then we were stuck on traffic because Memphis is an hour away from us, and there was an accident, and then we were stuck. We had left an hour and a half, and then I ended up calling the clinic. The appointment was like at 4 on a Friday. And then she said, I told her, I'll probably be there at 4:20, 4:25. We will be there. She said, if you're not here within 30 minutes, don't show up. And I told her,
Wow.
well, it might be like 30 minutes, 31, 35 minutes. And she said, sir, I'm telling you, I will, like Baha said, I will get fired if I check you in. There is a camera looking at me. If you
Wow.
are not in front of my face before 4:30, don't show up. We made it, but come on. Just come on, give me a break. I called you. I told you I'm stuck in traffic. You are still there till like 6, you said, but she said she'll get fired if she checks me in. And that's a big system, absolutely.
Big system are difficult to deal with. There is a physician was telling me in Baha the other day. They told him you need to take some days off because you reached your limit of RVUs. You cannot see more patients, and there is a huge need for that specialty.
That's true. That's true. Muhammad, Salam, you have a question. Go ahead.
Thank you all for the great discussion. It's good to see all of your faces again. So I just wanted to kind of bring up a couple of points. There are some specialties, and we had this discussion on the JAPA group multiple times, but there are some specialties that cannot have a clinic, and you can't really build a real estate off of it, like critical care and hospitalist services. They can have a group of people that can be practicing independently, but those groups are very quickly being eaten by either a big system like a university hospital or a big system like pediatrics, for example. I'm a pediatrician, so I only know those kind of situations. Uh, so that's something that I would like to get your insight on. And the other point I wanted to bring up is that there is a growing population of critically ill, complex patients who are trach, G-tube dependent, ventilator dependent. They are putting a lot of pressure on the medical system, and they have it could be like a market I don't know how to say it in a better way. I don't look at my patients I work at a university hospital, so I don't look at my patients as money makers, but there is a need for post-discharge care where those patients need to go to and be taken care of where they don't. And they're basically traveling in ambulances all the time to go to one visit. Like if they want to go to the pulmonologist, they have to go in an ambulance to the pulmonologist. The next day they have a visit with an ENT doctor. They have to travel again. It's costing a lot of money. But I think there might be a model of some sort that we can kind of brainstorm about and talk about for this population. Sorry for the two questions.
Thank you, Muhammad. Any comments on
I can take a stab at that, and I'm sure that I'll be interested to hear what the other doctors have to comment about that. But yeah, there are specialties which are mainly oriented and developed for inpatient care. And so obviously with critical care, you're a critical care physician. That's mainly what you do. You have to be involved with critical care units, and critical care units, almost by definition, are going to be in inpatient facilities and in hospitals. So it's tough for you to have a clinic, but if you create a private group, as part of a private group, you will need offices for administration, offices for staff, offices for billing, stuff like that. So there'll be real estate needs for you as a private entity if you have a group, even if you have to be affiliated with and contracted with a hospital. So there is that. And the second point is very well taken. I mean, we've talked about outpatient clinics, we've talked about diagnostic centers. There are ambulatory surgical care centers, which we haven't talked about, urgent care centers we haven't talked about, and then there's nursing facilities, long-term care and nursing facilities. And those are huge areas of real estate, and there's a lot of demand for that. And again, as we're talking about an aging population and increased demand for healthcare, there'll be much more increased demand for all of that. And how that will be in the future, will it be again a centralized location for those facilities? Will it be several smaller locations spread out in a different geography? And how the care will be provided? Will there will be physician services that will go to them versus them being taken in an ambulance to different outpatient clinics? I think there are definitely different business models that could be proposed. And in a marketplace, the good quality ones will definitely rise to the top very quickly and will succeed. And that's something, it's outside the scope of this talk, Mohammed, but it's something we can definitely discuss in other groups and figure out how we can make something like this be worthwhile.
I want to add, just continue what Amjad started on the second point. We were approached by a group, primary care, who covers nursing homes and long-term acute care facilities, to have neurology cover in those places. Of course, if they want to send those patients, the patient has to be stable to send them to the clinic. As Muhammad said, a lot of them might be on a vent or something like that. So maybe a business idea that we're thinking about, maybe just hire some mid-levels and train them well so they can cover those facilities, so they can provide care that they don't have to wait for a long time, or might have some difficulty getting there, or they end up being in the hospital for a simple disease or a simple complaint that can be addressed while in that facility. So that might be something that can be done, but that approach really cannot be done through a bigger system. That's when independent physicians, they come in and can figure out something for that. And we are in the process for looking into that.
Nimble gives you flexibility. That's a beautiful part about being independent and small. You drive efficiency at a bigger complex level, but you add bureaucracy to it. So the efficiency is immediately burned by bureaucracy and lack of quality. For us, it's all great news because we've been kind of focused on what do we do in the medical space, medical office buildings, for our investors at InvestStream. And we've kind of identified two criteria, and there's a lot of great gems that were shared today that kind of gives us that confirmation of, not necessarily being hospital adjacent, because a lot of the medical hospital systems build their own towers next to the outpatient towers next to the hospitals. So, and most of these buildings, some of them are full, but you can always find vacancy there. So if you try to be around the hospital, you're just adding more inventory. So we try to be a little bit further, but not too far, and more in a suburb area, away from the central business districts or downtown or historically where hospitals were. That's one criteria we're identifying. Obviously, Houston, Dallas, Oklahoma market is kind of what we're aiming for. And then the second is actually those satellite standalone small footprint clinics, whether in the context of a single tenant office park or what Yousef called a medical community, which is like, okay, it does feel like an office, but everybody is a doctor, dentist, and maybe there's an insurance agent and a financial advisor in the mix. So it gives it that upscale feeling, secure feeling, but still within 5, 10, 15 minutes from where the patients are. So I really appreciate your time, all of you, Amjad, Isam, Baha, and Yousef. I know we went a little bit over, but it was an exciting conversation. Appreciate all the insights. Is there anything we didn't cover, Sammy, so far in terms of questions or anything before we close?
Yeah, it looks like we got all the questions answered through the chat. Yeah, thanks everybody for your great questions, your great feedback, and thank you to our panelists. You made my job really easy. This was really fun.
Enjoyed it.
Thank you.
Thank you for having us.
Thank you, guys.
That's great.
Thank you.
all.
Thank you, everyone. We'll see you at the March next webinar in March.